All right. Yeah, now you can take it away, Dr. Flaherty.
Okay, got it. Hello, welcome back, everybody. Were you all able to do some PowerPoint slides? Yeah, good, good. And let's see, who do we have? We have, how about Eileen, who did you work with? I'm just gonna randomly pick someone here.
I'll pick with Mahala.
Okay, so you guys are on the bottom of the screen. Do you feel comfortable going first? Give it a shot.
Maybe.
Sure.
No pressure, no grades, just give it what you got here. So, all right, so you guys will share your screen, I guess. Great. Okay.
Okay. So for question 5, the question was, what are the possible causes of delirium? And I found a couple, but the one that related most to the case for me was chronic or severe illness, which I related to the dementia that she had. And the presence of dementia made the patient more susceptible to developing delirium because of the cognitive impairment that the dementia caused. So that was one. And then as for delirium, it usually starts rapidly within a couple of hours or days, which was present in Miss Johnson's case because the next week her symptoms presented themselves dramatically. And then as for Miss Johnson's Alzheimer's dementia relating to her developing delirium, Alzheimer's dementia has kind of been linked with the development of delirium, although there's still research on how they correlate. So I just found a couple of clinical studies, like according to the National Library of Medicine, about just the relationship between delirium and dementia. So yes, and that's present in the charts and the tables as well. And then table 1 just compares like delirium and dementia. Table 2 has some like trials about the connection between delirium and dementia.
Systems of care. So we define system of care as a broad, flexible array of services that supports for defined populations that's organized into a coordinated network. So I didn't find anything like really obvious, but I mean, I tried different things into the input, but none of them really have like really distinct results. But there are lots of research institutions, however. So maybe this is an area like that is something that shows that dementia needs more like attention and care.
Did you search under delirium for this part?
Yes, delirium.
Okay. Okay.
I don't think this slide is updated. Can you like exit and come back?
Oh, there we go.
Yeah. So when the patient is unable to cooperate with her care, which in this case, Ms. Johnson, I found some tips on how to deal with not how to help confused patients, such as be calm and patient and address the patient directly, even though they might not cognitively may not be their cognitive best, I guess, and speak slowly at a natural pace and generally make them feel safe. It's good if the place is like well lit and like generally open. So it's not like they wake up like in a closet. Yeah.
Good. That's right. Okay. All right, pretty good, pretty good. So you did questions 5, 6.
Let's see.
9, 8, 9.
Yeah.
That's good. Oh, right. Okay. All right, covered those. Okay, how about, did Lily show up? No? And who's this? Renee, who was your partner?
My partner was Sean.
Ah, Sean.
Did you want me to present his information as well as mine then?
I guess so. I
Okay.
guess so. Is that all right, everybody? For the sake of time, so we can keep going? Yeah, let's do it.
Okay. Right, so our questions were 3, 6, 7, and 10. We split it up so that Sean was doing 3 and 10, and I was doing 6 and 7, since 6 and 7 are kind of interrelated. So for Sean's particular question, it was, I'm forgetting exactly which question it was, but here's some like statistics. So delirium prevalence varies according to like the clinical setting, with 5% in minor elective surgery, but up to 80% in intensive care unit patients. So it's kind of like, it affects people differently depending on who goes where. And from the US National Library of Medicine, delirium affects an estimated 14 to 56% of all hospitalized elderly patients. And then around 20% of the 12.5 million patients over 65 years of age hospitalized each year in the US experience complications during hospitalization because of delirium. And so that kind of emphasizes how it's a pretty big problem sometimes because it's hard for people to recover from that. Here's some references. For my question, I'm pretty sure I was supposed to do this question. I don't know if this is actually number 5 or anything, but I also did causes of delirium, and
Good.
I like specified it a bit more. So I kind of talked about how delirium, like it's coming from a variety of factors that make the brain susceptible and therefore can cause disruption in normal processes. And it's usually because like the signal sending receiving in the brain malfunctions. And some causes include certain medication, alcohol, drug use, like Mahalo was previously saying, severe illnesses, and fever or strong infection, especially for children. And so I guess this kind of reaffirms the fact that like delirium doesn't only affect elderly, it also affects other people as well. So for example, like if children have strong infection, then it can affect them as well. Urinary tract infection can also be a cause for delirium. And this I found interesting, which was like malnutrition or lack of water or like sleep deprivation in general, which I think affects a lot of people in general. And so I think, again, like it reaffirms the fact that this doesn't only happen to elderly. And if you have like brain disorders like stroke, dementia, etc., it can also have an impact on whether or not you get delirium, visual hearing impairment, or if you have multiple medical conditions coexisting at the same time, that can also affect whether or not you get delirium. Some more is like the way we organize the environment. And so I think Eileen kind of mentioned it as well. But for example, if hospitals have location changes or like uncomfortable procedures, disruptive sound, or lack of quality of lighting, like particularly natural lighting, and if sleep is constantly being disrupted, that also causes delirium because the way we organize it can be very disruptive. And so that's one thing that I also found interesting. And genetics can also affect the likelihood of delirium. So if a patient had a long history of cognitive disorders in their family, then that can also affect whether or not they get delirium. And these are my references. And for number 7, which was about like what I do, like what would the doctor do? So I kind of talked about like how we would approach it. So first I thought it would be good to find out like the family history, because it would be important to find out if there were any illnesses before that the patient had, or impairments in their families or anything like that, and genetics in general, just to see if that's a major cause. And then because one of the other causes was medication or drug use, I said that we should also find out if there's been any prescriptions or any knowledge of any medication or drug use that the patient had in the recent history, as well as, I think this one's also pretty major, but how well the patient is eating, drinking, or sleeping, because that can also be something that we can probably easily find out, and it can still factor pretty like a lot into the cause. And again, like tracking the environment. So because like the natural lighting or like the amount of sleep, the sounds that go on, those are really important in checking out, and particularly in the assisted living facility to see what's going on there. And the references I just got from looking at question number 6 for the causes. For Sean's, I'm not sure which question this was, but while delirium cannot be cured, antipsychotics such as haloperidol, if I'm pronouncing it correctly, are given to roughly around larger than 10% of ICU patients to reduce like the agitation that is experienced. And not every case of delirium should be treated with antibiotics. And whenever antipsychotics are used, they must be started in lower doses and then slowly increased, just for like adjusting. And I'm not sure how to pronounce that, but that particular drug can be used when delirium is caused by sedatives or as a result of alcohol withdrawal, or like kind of like just drug use in general, I think. And there's many non-pharmacological treatments, such as just maintaining communication and reorienting the patient, which I guess kind of goes with what Eileen was kind of saying earlier, like we should be like treating them very well, and also just like adjusting the environment so that it suits the patient well. And references. And I think that is the main part of our presentation.
Very good. Quick question back to the causes in this particular patient. What happened a week before she developed the delirium? What?
She just moved to.
Wasn't it just normal? Like everything seemed normal, and the doctor said they were fine.
Oh, she just moved to a
Oh, right.
new environment?
She moved 1 month ago. And then I'll read you the sentence. She met the doctor about a week ago when her mother saw the doctor at the assisted living for the new resident history and physical. And then the very next Friday, she noticed her mom wasn't right. So what could have happened?
So I guess that could be like an uncomfortable procedure, like it wasn't handled correctly, maybe.
Oh no. Okay. What you'll learn this. What do doctors love to do?
Ask a lot of questions.
Yeah. Medical doctors, they love to order medicines. So could he have ordered a new medicine that she started, and then it happened, things started to change, and then that week later, everything kicked in? Yeah. So that's just part of the clues from the story. Yeah, good. So always, that's one of your highest risk with delirium is medications. Very good. Okay, and I'll go over some of these in my presentation. I don't want to stop the flow here. So now that Kyla and Lily, you guys want to go?
Yeah.
Good job, Renee.
That's great. Oh wait, this is the last question. Okay. Oh no.
8-11.
Okay. Okay, so we did questions 4, 6, 8, and 11. So for number 4, the question was, is it normal for older people to get this problem? So I don't, we found that it wasn't necessarily normal, but it was definitely more common. And it was specifically common with people in underlying and predisposing conditions, also in older age and neurocognitive disorders or changes. And about 1/3 of older hospitalized patients become delirious. In a study examining Indian ICUs found that incidence and prevalence rate of delirium were 24.4% and 53.6% respectively. And here's our sources. Lily, do you want to go?
Yeah, okay. So for possible causes of this problem, dementia is the biggest risk factor for delirium, and issues involving just with body involving pain, infection, head trauma, and poor nutrition / dehydration, abnormal metabolism or emotional disorders like including stress, anxiety, and depression, including just also changes in the patient's environment could cause delirium, and it could also involve just drugs and withdrawal or changes in medications, as previously mentioned.
So for number 8, are there any special considerations the emergency department needs to keep in mind? They should keep in mind that like how far the delirium has progressed and like how many like environmental changes they've had, or like what is effective in their environmental changes that's helping aid the delirium. And they should also keep in track their pharmacologic management or like their medications they've been giving them. Like some narcotic medications only, like the narcotic medications are only to sedate an agitated patient and only for acute pain. Some non-pharmacologic management, just reorienting the patient's surroundings, putting familiar objects around them, and encouraging family members to visit. A case study found that a non-pharmacologic intervention improved delirium resolution during hospitalization and cognition at 6 months.
And for just hypothesized underlying physiological mechanisms of this problem, just neurotransmitter abnormalities, alterations and decrease in cerebral metabolic activity, just causes from all those listed. And as compared to the younger, healthier patient, an elderly patient can enter a delirious state when exposed to a simple, I'm not sure how to pronounce this word, but noxious insult or precipitating event.
Good, very good.
And we're done.
Is that it? Okay. All right, excellent, everybody. You all definitely hit some of the highlights, high points of, and you did some good literature searches. And I'm gonna try to take you through more details. I'll do it quick, and if you want the PowerPoint, I'll try to send it to you. Let me see if I can pull this up here. Oh, I gotta be able to share my screen, don't I? Hang on. Share screen. What is that? Are you all seeing my screen? Not yet.
Not yet.
Okay. Go back to my Zoom here. Oh, sorry. Okay, now we go. Okay. Now, you got my screen?
Not yet.
Yeah, let me try this. Share screen. Oh, I got it. I had to hit the right thing. Got it. Okay, now we're ready. A little delirious here. All right, how about now?
Yeah, perfect.
Good, good, good. Okay, perfect. Are all these in the way here? Okay, move that over there. Okay, I'm going to take you through a lot of the questions. You guys have covered a lot, but I'm going to fly through these here, hopefully. Cover these objectives, what it is, why it's important, who gets it, where do we see it, and how to diagnose it. This is kind of progress in the field. I put this slide up here to remind everybody. The first book on delirium was only 1980, so only 40 years ago. So this is a relatively new field, and then all these things have helped or come out since 1990. So new field. Let's see. Can you see the right side of this over here? Yeah. So since 2001, past 20 years, if you hit PubMed and you hit delirium, you'll get 15,000 results. So quite a few publications coming out. Now, the bad news about delirium is this was a big meta-analysis. And in the past 30 years, no big studies have really impacted mortality. So we're making progress in screening for delirium, identifying it, figuring out ways to manage it, but to improve mortality, people still haven't done much in the way of that. So what it is, if you think about the brain, I like the term acute brain failure because it describes what Dr. Lepowski did in his book, is it constitutes a cerebral functional decompensation caused by a physical illness. So there are technical terms that you'll remember when you read about delirium, but I like this one because it's very descriptive. Here's, someone had a really good slide on dementia versus delirium. And the reason this is so important to know is that, as you alluded to, dementia is the biggest risk factor to develop delirium. And if you understand, a risk factor is different than a cause. And this is always tricky to understand, like obesity, being obese is a risk factor for diabetes, but it doesn't really directly cause it because not everybody who's obese gets diabetes, but it puts you at risk to get that. Same thing, driving 120 miles an hour on the highway is a risk factor for car accidents. Not everybody crashes, but it's a risk factor. So same thing with dementia. It's really sets you up for delirium. So on the left hand side is how you diagnose dementia and the types of dementias. And on the right are some diagnostic criteria. But look in the middle here. This is the tricky part. And I'll be honest, having done this 25 years, doctors and nurses in hospitals struggle. They really struggle on what to do with the behaviors associated with dementia or delirium. And as you guys talked about, what's in the literature, but I'll have to say it's not correct. What's in the literature is there are drugs that we use as last resorts, like Haldol or antipsychotics, to sedate people. But it might not be the best thing to do. But that's what's in the literature right now. Okay, we already talked about the seriousness of delirium, hospital complications such as getting tied down. They can't sit still for their tests. They pull their IVs and lines. They lose physical function. They go to nursing homes more often. They stay longer, and they even die more often. So people with delirium and pneumonia compared to just people with pneumonia, same age, same everything, except if one person has delirium and pneumonia and one has pneumonia, that person with delirium has a higher chance of dying while in the hospital. It probably doubles your risk of dying if you have delirium. And then, can you think what this might mean? Long-term cognitive impairment. this just refers to, I'm going to skip this slide. So let me try to explain what that is. This is information coming out of Vanderbilt University for the past 10, 15 years. They looked at some of their ICU patients and that had delirium, and then they followed them for 3 months and then 12 months. And supposedly delirium should go away and the brain should get back to the way it was, but they figured out that not everybody gets back to the way they were. So having delirium when you're sick may do some brain damage, And I know you guys aren't neurologists or radiologists, but doesn't this brain look a little shrunk? You know, it should fill up if we did a brain scan of you guys, your whole skull would be full of brain tissue. That's good. So how old do you think this person is? They look pretty old, but unfortunately they're only 49 years old. This poor lady, she was a very active young person, had a very high IQ before she got sick. She was in the ICU with sepsis, but she also had delirium. And she kept complaining to doctors after she got out, but they didn't really recognize it till the bottom was 3 years later. And they're like, oh my gosh, that delirium episode when you were in the ICU really did have an impact on your brain. So that's why delirium is so important in addition to dying and all that stuff. So who gets it? We already talked about people with dementia, but there's also people who are just frail. If you're 85 and thin and malnourished, and then the more severe your illness is. And so here's depicts two type of patients. Your frail patient with a frail brain, look, it might only take them one little infection, respiratory tract infection or UTI. But over here, the young person with a good brain, you're going to have to be very, very sick to get delirium. So if you're wondering, how does a urinary tract infection cause delirium? Well, it probably only causes delirium in a very frail person with a frail brain. Where do we see delirium? You see it everywhere in the hospital, young, old, middle age. And then here's some statistics that you guys already went over. Oncology ward, hospice settings, very common, end of life, surgery, et cetera, et cetera. Okay. So look for it everywhere when you get into, if you get into med school and you're doing rotations, look for delirium. Now, how to diagnose it? First is, you'll hear this agitation word. Agitation is not the same as delirium, right? Because agitation can happen in patients with dementia and delirium, and patients with dementia and delirium. Some patients have both. So here's the criteria. There's this book called the DSM, Diagnostic and Statistical Manual of Mental Disorders. That's the Bible for psychiatry. Now, unfortunately, delirium is still based on a psychiatry book, but we use it in medical terms and surgery. But that's the criteria, the gold standard, this disturbance and level of awareness or attention, acute onset, have a medical condition and fluctuate. So that's how you diagnose delirium for sure. It's not just acute confusion, but that's the formal diagnosis. Now, you can screen people for it using all these fancy tools. These are very short, 3 questions, 4 questions, and they're pretty accurate, All right, let's skip that. Now, how can we prevent it? Can we prevent it? Well, this study that came out in 1999, this is probably one of the best journals in medical journals in the United States. And it was a multi-component intervention to prevent delirium. So delirium is common in older people in the hospital. If they don't come in with it, they're high risk to develop it. So Dr. Inouye and her group, they looked at people who had risk factors, okay, baseline dementia, eye problems, adding some medicines, restricted. Anybody who had this got the intervention or usual care. And the intervention was better sleep. So here's that system. When I asked you that question about, are there any systems? This study resulted in a system called the HELP program, HELP, Hospital Elder Life Program. And so they've copied this research study and taken it to other hospitals, and other hospitals are very good now at preventing delirium if you do this protocol. And her results are, they don't look too dramatic, but usual care, 15% of people develop delirium, and they got it down to about 10%. So if you save a third, 30% of people from getting delirium, that's better than most drugs, okay? So that's pretty good. So that's one system. How do you manage it? First step in managing it is don't miss the diagnosis, because if you miss the diagnosis, you might miss the underlying medical illness. So I predict that one of you, when you're in the hospital sometime in the future, someone might say, oh, that person just has dementia. So you're not going to look for a urine infection or the medications or this or that, but they might start to be having a very serious medical illness. And you don't want to miss those medical illnesses causing the delirium. And here's my list. This is the list I use every day. So I use this mnemonic called delirium is painful. And so I check every patient's drugs, new and old, withdrawal or not. I see how their eyes and ears, if they don't have glasses or they don't have their hearing aid. Low O2 insults are talking about heart attack or stroke. That's oxygen deprivation to the heart or the brain. We talked about infection, retention of urine. If the bladder doesn't empty, the bladder gives signals to the brain and it affects the brain, and this can cause a very agitated delirium. One of my favorite causes of delirium because it's fixable. You just drain the bladder and the person calms down. Seizures can cause delirium, dehydration you already mentioned, metabolic, immobility, you talked about that, sleep deprivation, and here's some more contributors. So I use a little checklist every day when I see patients with delirium so I don't miss something. Now here's the hard part, is how do you manage all these? If they're agitated or they're hypo alert, you have to have a management system. So there are some systems of care. Let's go back here. I'm going to skip this for now. All right. So here's probably why these patients die more often in the hospital, stay longer. It's not the delirium or the dementia, it's all these behaviors. You can imagine if people are pulling on lines, climbing out of bed, getting tied down, they're not going to do well. So we have to have a system that develops this. Physical restraints should not be used in delirium. They're more dangerous than they help. Okay, but I promise you, you'll see them, you'll hear about restraints, you'll hear doctors, well, what else can we do? Well, there's other things we can do. What about the drugs? So you mentioned these antipsychotics. So this is the review trial. We did a review paper and we found out that there were 6 randomized controlled trials of antipsychotics in the perioperative period, 4 in the ICU, 1 in palliative care. And I'm not going to belabor this, but none of these worked. None of these worked. So why don't these things work? Well, here's the mechanism. So Kyle, I think you guys tried to describe the pathophysiology. So some of you who are interested in neuroscience, if you want to read this paper, it's a very long paper. It's got like 400 references, but it goes into detail about the complexity of delirium and all these hypotheses. So I'm only going to focus on one. Remember the neurotransmitters that you talked about? Very interesting area. Neurotransmitters look like this. This is the mechanism with neurotransmitter. So this is delirium neurotransmitter. That one little section about delirium is what this looks like. So very complex, very complex. Now, here are the antipsychotics that try to treat or dampen those neurotransmitters. So these are types of neurotransmitters that you will learn about or you have learned. There's dopamine, 1 and 2. There's histamine. There's adrenergic. These are serotonergic, muscarinic. So these are pretty cool areas to learn about. But you can see these drugs that are used. By the way, these drugs are FDA approved for schizophrenia. So schizophrenia is what people have if they have auditory hallucinations. And maybe you've seen the movie Beautiful Mind, the guy who had schizophrenia. These drugs are life-saving for people with schizophrenia. But for people with delirium, you know, you can imagine giving them one of these drugs, you don't even know what the mechanism in the brain is. So you're really shooting in the dark, like a shotgun approach, or, you know, you're throwing arrows up there trying to hit neurotransmitters. And that's probably the reason why they don't work. We don't have a specific neurotransmitter drug that hits the neurotransmitter that's causing the delirium. So way away from prime time finding a drug to slow down delirium at this point. The word you couldn't pronounce was benzodiazepines. And one benzodiazepine is Ativan, also called lorazepam. Benzodiazepines are very useful for anxiety. They relax people. But they should not be used in typical delirium. The exception to that was alcohol withdrawal delirium. You can use benzodiazepines, but even though they cause delirium in that situation. So we should not use Ativan, because sometimes when you use Ativan, it makes things worse with delirium. So no benzos during delirium. And this was a study we did at our hospital. I looked at everybody 70 and older for a year and a half. And I looked at risk factors for dying. Like here's one, here's cognitive impairment. Cognitive impairment. Can you see my arrow? Okay. So cognitive impairment among this group of 70 plus people, 6,000, 28% had cognitive impairment. Their mortality was 8.6% compared to those without, okay, which was 5%. A little higher, a third higher, okay? ICU stay, 25% stayed in the ICU. 17% of those people in the ICU died as compared to people outside the ICU. So if you go to the hospital, don't go to the ICU. They may kill you, okay? They may increase your mortality. Now, of course, that's not right. It's the people are sicker in the ICU. Now, but here's the funny, the sad thing is people who get this IV Ativan, lorazepam, 15% of old people got it for some reason, and their mortality rate's like 6 times higher than people without it. So we don't know why they're getting it. I mean, I know why sometimes. It's to get tests done. It's because they're agitated. They don't sleep at night. There's a plethora of reasons. But we know from this observational study, that's not a very good drug to give old people. Okay, so the experts, this is an expert paper. And I know some of these people who wrote this article, and they are truly the experts in the field of delirium. Everybody completely respects their research. So they say pharmacological treatments are not effective, and they go through the reasons in their paper. So they say managing the distress and the complications, paying attention to environmental issues. So you guys hit the nail on the head talking about the environment. Now we have to know what to do, though. You have to change the environment. So triggers are things that bother the patient to the point that they can't cope and they can't handle these things. So if someone at 6 in the morning still sleeping and the doctor comes in, starts asking too many questions, that's too much stress. How about checking your blood pressure at 3 in the morning? If you guys were in the hospital for the flu, would you want nurses to wake you up at 3 in the morning? Check your temperature, check your blood. No, this is the standard in hospitals. NPO means nil pro os. It's Latin, means nothing by mouth. And we make people not eat because we're afraid they'll choke or something. Then they get hungry, they get upset, not allowing them to get out of bed, tethers, things like that. So we have to change the environment. This was actually, I drew this picture because I couldn't take a picture of this patient, but this was a true patient at St. Louis University when I was there. And And this guy had a urinary catheter. He had these things on his legs that pump the legs to prevent blood clots. So there's 3 things tying him down. He had 2 restraints on each arm, or 1 on each arm. So there's 5. He had an IV in. He had the feeding tube in his nose. He had the oxygen, and he had these things on the bed so he couldn't climb. It was like 10 different tethers and restraints. So by the way, you know how we fixed this guy? I undid a lot of this stuff, got rid of the catheter, sat him on the side of the bed, and we did this for 3 or 4 days in a row. And by day 4, he's talking, and we were able to discharge him and get him out of the hospital. And we stopped a bunch of the drugs they were giving him. Okay, so that's why can't confused patients cope? Oh, here's the answer. So what do you think is going on in this guy's brain? Why he's getting agitated? Let's go back here to the mechanism. There's this thing called network in your brain. And there's a network disconnectivity. So the prefrontal cortex in your brain is communicating with other parts of your brain. In fact, they're doing it right now. Your parts of your brain are communicating with other parts. So here is a normal subject, normal person. The light up area are parts of the brain that are clicking. Okay, when people are thinking and feeling emotions, here's the emotion part. I'm happy, I'm sad, I'm angry, but the prefrontal cortex is controlling that. I'm curious. And so everything is connecting. Now, unfortunately, the delirious patient, look what's going on. The prefrontal cortex barely lighting up, not working. So the delirious patient is all going on this lower part of the brain. Part of it's called the amygdala. If you read about the amygdala, it's full of emotions. It's full of emotions. And so the poor delirious patient that's having all these agitated behaviors, I think I've got this. Yeah, here it is. So the unstressed person has tight control over their thoughts and emotions. So the prefrontal cortex is controlling those. But the stressed person or the delirious patient, all that emotion, all those thoughts and actions, prefrontal cortex isn't working. So it's coming out. So we can't change this until we get rid of the delirium, but what we can do is change the environment and our approach. Once you know this, I teach nurses this, and once the nurses realize that they can't reason with a person with delirium and they're just emotional, they figured out how to deal with the patients. So 2 more systems have been developed to deal with delirium patients. The one on the left is called a delirium room or a delirium unit. We developed that at St. Louis University back in the 90s. And the one on the right has to do with intensive care unit. And intensive care units have developed these models of care that have to do with early ambulation, among other things. So I'll show you those 2 real quick. There's the original delirium unit. It was 4-bed, never used restraints, always have a nurse in the room with the patient, and we put the patients together. How about that? Here's our data. The delirious patients versus the non-delirious patients, lower mortality rate, about the same here, non-statistically significant. We had some pretty good outcomes. This has been replicated in Hong Kong, Chengdu, China, and 3 places in Australia. They didn't replicate us, but they were doing it kind of the same time. And they've had different kind of delirium unit type units for delirium. Here are the 3 studies, 2 from Brisbane and 1 from Perth. One of them called it's the DOS-U. Here's a delirium bay. And they've had pretty good outcomes, not just with delirium of mortality, but with other things. So the intervention group had somewhat suggestive of lower mortality. So if you do the right management with environment, you can really improve outcomes with delirium. And that's our method. So here's the most amazing. This was an original study by therapists, 2 therapists, PT and OT. And they got patients out of bed. See, this guy's on the ventilator and he's on IV drips. This is somebody, when I was younger, we would never get out of bed for like a week or 2. until they were completely off the ventilator. Now the standard should be getting out of bed. Here it is. The intervention group, get them out of bed within 1 to 2 days, even if they're septic, on a vent, in their mouth, everything. Just get them out of bed. And the outcome is they have 2 days of delirium instead of 4. They return to their function 60% of the time as opposed to 35%. So good outcomes, and people have replicated this. This is my last little, this is not a system of care, but it's a nice little factoid that if you have an old person laying in bed and for day after day after day, and there's something called the coma scale. And so if you're 3 on the coma scale, you're almost in a coma, basically. If you're 15, you're normal. So this group of 17 patients, all they did was move them, sit them on the side of the bed, and their coma scales went from 7 to 11 on average, 30%. So you can just, you guys try this. When you study in bed, laying down flat, your brain's not going to work as good as if you're sitting up. Okay, has to do with something called the reticular activating system of your brain. Has to do with that connectivity. So there's a lot part of the brain that start to kick in when you're upright, as opposed to having your head on the bed. Oh, this was our study. We just got this accepted for publication this past summer. We looked at the program here in Dallas over 3 years, monthly mortality rates. And by implementing the Delirium Unit and implementing consults and some other things, we showed that people with cognitive impairment, delirium or dementia or both, had a mortality rate of about 8% on average, down to about 5% over 3 years. Patients without cognitive impairment, no change, about 5%. So we decreased mortality by about 40% over 3 years using those geriatric principles. All right, so in conclusion, delirium is brain failure. Don't forget about frailty, who gets it. We see it everywhere, how to manage it. Don't forget the checklist in conclusion, and don't forget the behaviors are overlapped. And, oh yeah, don't forget that slide. Prefrontal cortex, keep your prefrontal cortex working. Don't use drugs, they don't work. And then get people out of bed, get them to the delirium unit, and they should have better outcomes. Okay, let me go back. I don't hit new. Try that. Okay, I guess you're still looking at my screen. Stop share. There we go. Okay. So, any questions or thoughts or, comments about any of that?
So like on a daily basis or like weekly basis, how many cases of delirium do you see? Or
So I'm in a hospital. The hospital here is 500 beds, and there's usually 2 geriatricians. The other one is out on maternity leave right now. So today I saw 22 patients, and not all new. I saw about 5 new people with delirium, and the other 17 I've been seeing all week. So, but the hospital doctors usually only call me for the most complex ones that cause a lot of trouble. They're climbing out of bed, they're pulling on things. And so I try to come in and triage these people. We have a delirium unit here at this hospital that we opened about 2 years ago. So I try to pick out the most needy of the delirium patients, move them from one floor to another. And then there's 5 beds in there, and then we try to get them better before we discharge them. So, but if I had to guess, out of 500, I'm sure there's 100 more that I never see. Hopefully they do okay. So most doctors know how to identify delirium, and most delirium gets better. So, but about 20-30% really struggle. Question. Before this, I was curious, did anyone ever hear of any grandparents having this, they would probably not even use the term delirium. They would have said they went to the hospital and got confused. Never heard of that. Okay. All right, well, hopefully you won't. But if you do, you'll now know what to talk about. Right. Did you find that neuroscience kind of intriguing? That's pretty, still baffles me. So maybe you guys can figure out how to help delirium by studying that neuroscience part of it. Okay.
So like, what does your daily life kind of look like at your work? Like, what types of patients besides delirium, or is delirium like a big part of what you see?
For me, it's a big part, but I think I'm an unusual geriatric doctor. Most geriatric doctors are in the clinic or the office a couple half days a week, where they see patients who walk in who have a little memory problem or high blood pressure, things like that. And then they see a few patients in the hospital. A lot of geriatric doctors go to nursing homes and rehab places. So that's a geriatric doctor. Most geriatric doctors are in universities because there's not enough geriatricians. So they kind of teach, and hopefully young people become geriatricians as well as see patients.
So would you say like geriatrics, like treating patients, is that more like a long-term kind of thing? So sort of like a progression, you have to check in on your patients a lot and kind of check how they're doing?
Yeah, most geriatricians out in the community who have clinics that follow people, they're almost like family practice docs, but for the end of life. So they'll take care of them from the age of 70. They'll see them every few months or every 6 months, and they'll try to follow them for 10, 15, 20, 30 years if possible. And not everybody over the age of 70 needs to go to a geriatric doctor. Typically, we get the patients who have cognitive problems, falls, polypharmacy, which means too many medicines, people who are not doing well out there in the community. So most internists will treat high blood pressure and diabetes and all that stuff. And then they'll refer their elderly patients to the geriatric specialist, just like they would if they have a heart problem. You know, if someone has a serious heart problem, your family practice doctor isn't going to take care of that serious heart problem. They'll refer them to a cardiologist. So same thing with geriatrician. The family practice or internist will say, golly, this 85-year-old is so complex. They're on 15 medicines, they're falling, they're forgetful, their wife can't take care of them. And that's that complex there. Yeah. But it's fun. I enjoy it. They say that the two happiest specialties are pediatrics and geriatricians. They did a study many years ago. They surveyed all these doctors, and they thought cardiologists would be happy because they make so much money, and they were kind of lower on the list. I think it's more stressful. So pediatrics and geriatricians are not as stressed as like oncologists, cancer doctors, and people like that. So, but do what you love. I mean, you got to find something you like. That's kind of what makes people happy. All right. Well, why don't we stop there? And then if you can always email Kyla or myself if you have any questions. Okay. All right.
Thank you.
All right. Thanks all of you. Good luck in your careers. Can't wait to hear in the future, maybe a year from now, send me an email. Let me know what you're doing getting through high school.
Thank
All right.
you.
Thank you. Thank you guys. Bye-bye.
Thank you.